attorney Catherine Henry, and I'm sitting here with Dr. Martin Dubravic, an expert immunologist. And in case you're just watching this video and haven't seen the prior ones that we're posting as well, I just want to let you know what we're here doing. We're talking about the COVID-19 situation, some specifics here to what's happening here in Michigan, but we're talking about a lot of things as they play out across the entire country and in some instances across the entire world. So with that being said, I'm just going to get right back into some of the topics that we've been talking about in these videos. So one thing I guess I wanted to ask about is, so we kind of briefly touched on the fact that there's the state senator who's also a licensed practicing physician in Minnesota who was concerned about the CDC mandates to report COVID-19 on death certificates and add it to the list of diagnoses where that isn't something the doctor would have done. It was also referenced in the interview by the two doctors out in California who had been seeing and testing over 5,000 patients to see if they have coronavirus, as well as some doctors who have been posting on Facebook some concerns about, some doctors from Wisconsin, I should say, who've been posting similar concerns about feeling the pressure from hospital administrators or the health department or other people saying that they need to add COVID-19 to the list of diagnoses for a particular patient. So that's where I'm going. I'm gonna ask more specifics about that. So as you, I guess probably the easier way to do this piece of what I'm thinking about is I'm going to explain what my understanding is, and then have you correct me if I'm wrong. Otherwise, tell our viewers if I've got it right, and so they can see what's going on here. But so specifically talking about, we've been looking at numbers of all those people who have had coronavirus or COVID-19, and then we're looking at the numbers of the people who have then died from COVID-19. So specifically what I'm talking about at this point is just those who have died from COVID-19. My understanding is that we have what is called a U.S. Standard Certificate of Death that is filled out every time someone dies in the United States. And it is filled out either by a primary care physician or the attending physician at a hospital where somebody was admitted through the ER, or it might be a funeral director, but there's specific individuals that fill these out. For viewers, that is available with a quick search, a quick Google search for U.S. Standard Death Certificate. That's how I found it, and actually the CDC's link with that very document, the official one, is the first one, first search result that Google displayed for me. So on there, there's a provision or a section, I believe it's section 32, parts 1 and 2, that talk about oh, I have a sample of it right in front of me, the cause of death, and they refer to an immediate cause of death with the underlying cause of death, and then part 2 of that section 32 talks about significant conditions contributing to death as well. So my understanding is that although we've been reporting causes of death in the United States here for, I'm guessing, many, many years on our own, that currently the World Health Organization has been requiring member countries to use their, I'm forgetting what ICD stands for, the International Statistical Classification of Diseases and Related Health Problems, which the current version is known as ICD-10. Is that correct? Correct. And this ICD-10 provides some guidance on how to identify the one single underlying cause of death where there's multiple things at play. It also gives the format for the death certificate and what that should look like, and provides that it provides the regulations on using the various classifications, or in other words, what we've been calling ICD codes. And so this is put out by the World Health Organization, and it is something that is meant to be standardly used in every single country across the globe for purposes, not just with COVID-19, but that's something that happens with, you know, reporting of car accident deaths or suicides or cancer deaths, right? And so this is something that has been going on for quite some time and is done across the world. In general, though, my understanding is that the World Health Organization is not directing or specifying to doctors I guess, how to do their job in terms of finding the diagnosis. That they're leaving that part up to the physicians and just instructing them on how to then take that information and fill in this form. Is that a fair statement? That the WHO is not telling physicians how to come to a diagnosis or which diagnosis to come to. They're just saying, well, once you have your diagnosis, this is how we want you to write it down.
Correct.
Okay. So with COVID-19 now, well, let me back up and say, as far as you're aware then, does the CDC require us to, in the U.S., then implement that those ICD standards and use that same standard format and use the same ICD codes when we're reporting causes of death on death certificates? As far as you're aware, is that what happens here in the U.S.?
Yeah, we have what's called ICD-10 here in the United States, which is formulated by the government in conjunction with the American Medical Association. So they have American Medical Association has a contract to update and manage the ICD codes for the United States. So there may be some slight differences between the World Health Organization and the United States, but the process is the same. Yes, and the goal with the ICD-10 codes is to try to put a very specific label for each diagnosis of illness or disease in a patient.
Okay, so as far as you're aware, the ICD codes as put out directly by WHO, or the World Health Organization, and then the ICD codes that are used specifically here in the United States are largely identical. We might have some nuances with different reporting aspects, but there's no significant differences between the coding as far as you're aware.
I'm not aware of significant differences, but I can't state for sure that there are some differences. I know that, but I don't know how alike they are. I do know that we've gone through revisions of the ICD codes in the United States, and it seems like the ICD-10 code is much closer to international standards or groups than ICD-9 was.
So I'm going to share some information that I pulled directly from the CDC website, and then tell me or share with our viewers if I'm analyzing it or understanding it correctly. For those who are viewing this, if you want to see where I'm getting this information specifically, I did publish a document on the internet. It's available on Facebook just from a couple days ago. That at the top it's entitled Baseless Conspiracy Theory or Simple Truths Unearthed Through Government Data. Like I said, it's available online, and I have the specific URLs where I access this information. Much of it was last accessed by me on April 23rd or 24th, so it's pretty recent. So this particular one I got from the CDC.gov website, the portion of the National Center for Health Statistics, and then within that the National Vital Statistics System. So it's talking about a cause of death classification, and it explains that, and this whole section is quoted right from their website. Mortality statistics are compiled in accordance with the World Health Organization regulations, specifying that WHO member nations classify and code causes of death in accordance with the current revision of the International Statistical Classification of Diseases and Related Health Problems, or ICD. The ICD provides the basic guidance used in virtually all countries to code and classify causes of death. It provides not only disease, injury, and poisoning categories, but also the rules used to select the single underlying cause of death for tabulation from the several diagnoses that may be reported on a single death certificate, as well as the definitions, the format of the death certificate, and regulations on the use of classification. Causes of death for data presented in the reports, the death reports, death stats, not just related to COVID-19, but all of our causes of death. They're coded according to the ICD guidelines distributed in annual issues of Part 2A of the NCHS Instruction Manual. So am I reading that to say that the CDC is putting out there that here in the U.S. we are going to follow, at least at this point, we are currently following the most recent ICD codes that the World Health Organization has put out? Is that what they're saying there?
They are, but I don't. But our formulation, our codes are probably slightly different from the WHO. Probably very similar, but we formulate our own.
Okay.
In the United States.
So, would you say? So, I guess let me get on to my next point of understanding is that, obviously, with COVID-19 being, we've had coronavirus around for quite a few decades, but this particular version of it, COVID-19, is fairly new, not just to us, but to the rest of the world. And so it wasn't until recently that the World Health Organization added some ICD codes so that when people are filling out the death certificates in countries all across the globe, that they have a specific way to reference this particular virus. Is that fair to say? Mm-hmm. And so the World Health Organization put out this ICD code. I think the long way of referring to it is U07.1 and U07.2. I'm just going to call them 7.1 and 7.2. But are you familiar that they've recently put out those two codes?
Yes.
And so in the information that is put out by the CDC, specifically the Division of Vital Statistics for the National Center of Health Statistics, which is all under that CDC umbrella. They put out information on March 24th that described these new ICD codes to physicians and others who'd be filling out these death certificates. I'm assuming that's the intended audience for these documents. Mm-hmm. And they reference that this code 7.1 is specifically meant for the COVID-19 deaths where there has been a laboratory confirmed test. So it's confirmed by lab results that yes, this person did have COVID-19. They also talk about, there is a second code that the World Health Organization has generated, this is 7.2, that is supposed to be for clinical or epidemiological diagnoses of COVID-19 where laboratory confirmation is inconclusive or not available, or basically the person has tested negative for COVID-19. That the World Health Organization is saying, we want laboratory confirmed deaths reported separate and distinct from those that are assumed to be COVID-19 related deaths. Is that understanding correct?
Yes.
Okay. So would you say that to the extent that there might be some nuances between how we use ICD codes here in the U.S. and how the World Health Organization is requiring every country to use them, would you say that keeping that distinction would be, if we were to use those codes differently than the World Health Organization is requiring us to use them, would that be a small change, or would you think that's more of a significant change to blend laboratory confirmed cases of any kind of illness with assumed or likely cases?
Yeah, I think we would use those codes just like they present them with, where the code says yes, definite, lab test positive, and the second code is a clinical diagnosis without a lab test. Which sort of begs the question, though, why do we need to have two codes? I mean, if we have accurate testing and we can test someone who has coronavirus versus and say with 90% or more accuracy whether or not they have it. Why are we having two codes? So that sounds a little fishy. There are certain diseases that are difficult to diagnose via laboratory testing that may have positive laboratory tests, but the patient doesn't develop a positive lab test. We have that all the time. But with this, it's pretty straightforward with the viral illness or bacterial illness.
So if you have a patient who has had COVID-19 in their system so, I guess so severely that they are succumbing to it and getting to the point of dying from the illness, that if that patient's blood was drawn or whatever the method is for doing the testing, that a COVID-19 test as we have them currently today, that would be able to conclusively show that patient had, if they did in fact die from COVID-19, a laboratory result would show that they did die from COVID. I mean, it would show positive for COVID-19?
Well, yes. Well, I would say, there was one study, the New England Journal study, looking at, published in March, where 20% of patients who had COVID-19 did not receive the diagnosis until they had some additional testing completed. So it depends on what type of testing you're doing. But you should be able to find it if you look hard enough, I guess is the way to look at it. And there are potentially patients who have COVID-19 who will not get a positive test. But that should be fairly rare.
So is that, are you saying that would basically be, as with any kind of medical situation or scientific situation, there's always going to be those few outliers with outside of the standard deviation of what we're looking at in terms of it doesn't always work 100% of the time?
Correct.
Okay, so...
Correct, but the vast majority, if they have died of COVID-19, the vast majority should have had a positive test. Okay.
So then I guess my question for you is, does it affect the... how do I want to ask this? As far as being, if you have a laboratory confirmed test result showing that a decedent had COVID-19 versus a case where a decedent has some of the symptoms, cough, fever, those kinds of things, and then but there has been no testing to confirm. Is there is one of these diagnoses more scientifically significant? Does one, when in terms of looking at death patterns or how many people are dying, is there a difference? Can we look at the presumed cases the same way as we're looking at the laboratory confirmed cases?
I don't think so, because the presumed cases could be from a host of viruses. The symptoms of COVID-19 are so nonspecific. What I mean by that is they are so vague, they can represent a whole host of viruses.
So, just to be clear for viewers, what you're saying is that all what the CDC or the WHO has released in terms of things we need to look out for, when you have these symptoms, that's when you might have COVID-19. Those list of symptoms also appear in several other viruses and illnesses?
Absolutely. Yeah. For instance, influenza, RSV, rhinovirus, adenovirus, metapneumovirus. So there are a whole host of viruses that can cause similar symptoms.
Okay. So in lumping all deaths these days in together and saying that these presumed cases, we're going to go ahead and call them COVID-19 cases, we might be able to talk about them as possible cases, but they shouldn't be just lumped right in with the same pile of conclusively testing positive cases of confirmed COVID-19.
Absolutely. Exactly. Absolutely not. They should not be lumped together. I mean, if we look, for instance, in the Munson healthcare system, which covers Northwest Lower Michigan, we're running above 80% of patients who come with COVID-like symptoms are testing negative.
Okay. So, does that mean then, because we've seen there's been at least some data being reported that the flu this season, in the last 2 months, that the flu numbers have just dropped dramatically. Do you think that's possible? It's possible that there are in fact normal patterns of flu spread in the U.S., but we are now more likely than not calling it COVID-19 instead of the flu when they might have some of the very same symptoms?
That is a concern. Definitely it's a concern. We don't know for certain. We just don't know for sure. For instance, what is the co-infection rate? So for instance, you can have more than one viral infection at a time. You know, unfortunately in the state of Michigan, as of just a few weeks ago, if a patient was tested influenza positive, we were not allowed to test them for coronavirus because they were given a diagnosis. And because of our rationing of test kits, a lot of patients who came back positive with influenza were automatically barred from being tested for coronavirus.
I'd be curious, do you think that would cut the other way? That if you have a patient who, let's say the medical provider is just under some serious pressure from their hospital system to quickly identify coronavirus, and so they jump to that test before doing testing for, say, the flu or other viruses or illnesses. If a patient does, in fact, come back as testing positive for COVID-19, do you think there are cases then where they don't even bother testing for the flu?
Absolutely.
So then that would severely hamper our ability to truly understand the total medical picture that the person is that particular patient is currently dealing with.
Correct. And I think that's been part of the problem in really looking at the scope of this illness is having the data, having the testing, knowing where this is going. Because, for instance, what if influenza was protective against coronavirus? Maybe that virus pushed out and prevented coronavirus infection, or vice versa. Maybe coronavirus prevents influenza infection. Maybe it doesn't. Maybe it favors co-infection. That would be unusual. Our understanding of viruses is that co-infections are rare. Certain studies have said anywhere from 2% to 20% of patients can be co-infected with more than one virus, but we don't know. And to say that, okay, you've got influenza, therefore you don't have COVID-19, we can't say that.
So if I heard you right, you're saying that it's possible, and it may have happened in other types of viruses or illnesses, that, say for example, it's possible that I could get the flu, and the flu might, if I also have been exposed to the coronavirus, that those, as the virus is multiplying and doing its thing inside of my body, that the flu virus could actually be attacking the coronavirus within my body and shutting it down from harming me. That's a possibility of things that one virus, when it's within the body, could be attacking the other virus. Is that what you're saying?
Well, I would look at it slightly differently. I would say that if you're infected with one virus, can the other virus get in and infect also? Because viruses are parasites. Okay, they are what we call intracellular parasites. That is, they don't live that long outside of a human cell. Okay, so they have to get into the cell in order to survive. So if they're in the cell and they're making that cell abnormal, is it possible that another virus is not allowed to get into that cell? That could be. We don't know. Bottom line is we don't know because we didn't test patients for both things. So we don't know what the co-infection rate is.
Okay. So would you say that now that we have more data, we have more time behind us, more cases behind us, that there's enough symptom overlap between, say, influenza and COVID-19 that it would be wise if we were in fact testing more patients for both to make sure that we are understanding what entirely their body is going through?
Absolutely. Absolutely.
It's It's a very interesting point that I never thought about. So I'm glad that you brought that up. So what, let's see, I did want to ask you some more about what the CDC is doing in terms of these codes. Just trying to figure out what my next question was. So, so let me ask you this. Right in this March 24th, COVID-19 alert number 2, coming from one of these departments of the CDC, there's a question on here. It looks like it's set up as like a frequently asked questions document for physicians. So this question says, will COVID-19 be the underlying cause? So it's explaining that, well, underlying cause depends on what and where conditions are reported on the death certificate. So in what order are you saying it's just related, or are you saying it's the cause of death, etc.? But it says, however, the rules for coding and selection of the underlying cause of death are expected to result in COVID-19 being the underlying cause more often than not. To me, when I heard that, I was thinking, this is a pretty much the beginning. You know, this is over a month ago now. This is being directed to physicians. So at the beginning of all this happening, when we didn't have enough data behind us, they're saying that even though we don't know what data will look like, what cases will look like, what the spread of the virus will look like, we are telling you that our rules and our procedures and our dictates here are basically, they need to result in you reporting COVID-19 being the underlying cause of death more often than you're not reporting it as the cause of death. Isn't that telling doctors what numbers they expect to see on a particular cause of death? Isn't that a little backwards, or is that how it's normally working? Is that what, are we normally telling doctors, well, I expect that you're going to put the flu down, you know, this many times, or I'm going to expect that you're going to, be reporting lots of cancer deaths this year? I mean, is that how it normally works?
No.
Okay.
No, and that, it sounds like predictive modeling in one way, and although they're not specifically, from what I understand of your reading of that, they aren't specifically requiring that, but they're saying that's to be expected. Well, they expected a lot of things, many of which were totally off. So
I guess something you said kind of sparked a thought. So you said it sounds like what's happening, with our predictive modeling, that it almost seems then that their directives are trying to encourage physicians to do reporting on deaths in such a way that it would then match what the predictions have been in their models. That well, we predict that this is going to be such a deadly, horrible virus, so we need the reporting to go ahead and show that. We're expecting you to go ahead and report that COVID-19 is here, even if we don't have these test results. So I guess I'm curious on your thoughts. One of these next questions says, what happens if the terms reported on the death certificate indicate uncertainty? So my understanding is that that's where, say, the attending physician who was treating a patient that was admitted through the ER, that physician has indicated there was possibly so much going on with this patient that we could not identify what has happened. They may, in fact, have had a COVID-19 test which came back negative, or a flu test that came back negative, or they could have had a whole battery of tests and nothing stood out as this is in fact what this particular person has. And so the medical provider, when the person passes away, the medical provider is left with marking the death certificate as basically an undetermined cause, or that they're uncertain as to what happened. So when the answer then, painting that picture for viewers, the CDC then answers this question by saying, if the death certificate reports terms such as probable COVID-19 or likely COVID-19, meaning there was no testing done, these terms would be assigned the new ICD code of 7.1. So they're going to be given the code meant for laboratory confirmed cases. Does that seem right? Is that how it's normally done?
No, because there's a second code.
Okay.
The 7.2 should be used in that case, not the 7.1.
I, as an attorney, found the next sentence also alarming, and so I want to get your thoughts on that. So it continues. The very next sentence says, so we're going to assign the code 7.1 to these likely COVID-19 cases. And furthermore, it is not likely that the National Center for Health Statistics will follow up on these cases. It's not likely that the government agency who's overseeing the reporting of all death statistics in the U.S., that they will bother to check in with that medical provider to see if there was anything more that could be done to confirm whether COVID-19 was present.
Or if subsequent testing, sometimes testing's done on autopsy, which could give an answer.
Right.
And those tests may take as long as 6 weeks to come back.
Okay. So it's possible that a death certificate would have been filled out prior to an autopsy showing whether or not somebody had the virus.
Correct.
Okay. So it's interesting then that at the bottom of this, and I had heard, I'd seen videos myself and comments myself that were coming from physicians across the country when the initial guidance came out actually on March 4th from the same agency saying, you know, we want you to report these cases as on the certificate of death. We want you to say it's COVID-19 even though you don't have a confirmed case. Go ahead and call it COVID-19. That physicians across the country were saying, whoa, that doesn't seem appropriate because we're people of science and there is a test that could be done, and yet the test is either saying no, they don't have it, or we just didn't even think the testing was necessary because of the other symptoms they were demonstrating. So when that concern was raised, the CDC then addresses in this frequently asked questions document on March 24th, should COVID-19 be reported on the death certificate only for confirmed or only with a confirmed test? So they're saying, should we go ahead and follow ICD code 7.1 the way it's designed? The answer provided here by this governmental entity is that COVID-19 should be reported on the death certificate for all decedents where the disease caused or, and this says in bold, or is assumed to have caused or even just contributed to the death. And that part is in bold right from the Stephen Schwartz, PhD, Director of the Division of Vital Statistics from the NCHS. So it seems pretty clear to me, and I want your take on this, that what they're saying is, yes, we know you're asking about should we follow the rules and regulations for using code 7.1, laboratory confirmed test. That is what the code being used by all the other countries in the world dealing with coronavirus right now. That should you just simply put the laboratory confirmed deaths in that code, or should you go ahead and just lump in any old case that you think, well, it could be that this person had COVID-19. Should you go ahead and do that? And to me, it seems like he's saying, yeah, you better darn well put it as, you know, the code for COVID-19 confirmed deaths, even though it's just assumed. Is that how you would take his statements here?
Yes, I would, and that's very troubling. That's not what we're about. We should be documenting the truth.
That's what I would think too. So let me see here. I wonder if there was something else. So you mentioned I think you used the term comorbidity or basically that you might have more than one illness or disease or health condition that has led to your passing. That is something that happens frequently. Is that?
Yes,
okay.
Absolutely.
So my understanding is that in the instance, though, that you have someone who has been, say, diagnosed with pneumonia. The doctor has diagnosed that patient with pneumonia and has specifically not diagnosed that patient with COVID-19. Even though they might have some of the same symptoms, that they are specifically diagnosed as having the one and not the other. That what on April 2nd, COVID-19 alert number 3 coming out from this same division of the CDC, says that these provisional counts for COVID-19 deaths are based on the current flow of mortality data and will include, among other things, pneumonia deaths, And then they explain this by saying pneumonia deaths are included in the provisional counts because deaths due to COVID-19 may be misclassified as pneumonia in the absence of positive test results. So please tell me if I'm wrong about this. What this says to me is what we're going to do as the CDC is we're going to go ahead and tell the media that we have this big, huge number of people that have died from COVID-19, and we're going to not only take those that have actually been labeling the death as 7.1 in the ICD code, we're going to go and grab this other category of of non-COVID-19 pneumonia deaths, and we're going to lump that right on in with those that actually are being reported as 7.1. Mm-hmm. Is that how you take that information?
Yes.
And the justification is that, well, you know, doctors might have screwed up and they might have called it pneumonia when they meant to say COVID-19, even though we're saying there is no COVID-19 positive test result. We're going to say that we know better than the physician that is actually treating that particular patient, seeing the symptoms themselves. Is that, am I reading that wrong, or is that basically what they're saying?
That's what they're saying. In my opinion, that's what they're saying, which is troubling because we need accurate data in order to formulate policy and in order to formulate therapeutic responses to the vaccine.
Okay, so getting to the issue of why it's so important. Also in April 2020, the same branch of the CDC talks about that monitoring and analysis of mortality data. So looking at causes of death statistics for all causes of death here that we see frequently in the United States. That doing analysis of this data is important so that we can disseminate or share critical information to the public and to shareholders like public health departments. And that one of the most important methods for mortality surveillance is through monitoring cases of death as reported on death certificates. So what they're saying is the CDC looks at the cause of death as listed on a death certificate, and that they look at all death certificates that are recorded throughout the U.S. and D.C. and so all of our states, and they compile all of that data and look at what the death rates are, and then they're able to compare, well, this many people died from COVID-19, this many people died from the flu, this many people died from a car accident or from cancer this year, and that's how they are able to shape the health policies that we have based on which causes of death are more likely in the U.S. That's what they're doing here with this data? Okay. So I found another interesting two sentences here. Appropriate completion of death certificates yields accurate and reliable data for use in epidemiologic analyses and public health reporting. So if I'm understanding that right, they're saying it's crucial that doctors fill these death certificates out correctly with whatever the diagnosis is, because we then take this, we extrapolate that individual's death record, and we compile that with all the other death records, and then we look at how likely it is that someone is going to die from this particular cause of death.
Yes.
And then they say then that monitoring the emergence of COVID-19 in the U.S. and guiding public health response will also require accurate and timely death reporting. So they seem to say something that's really obvious to me, that we have to be super careful about how we fill these out. We have to be accurate with what we're putting on these death certificates so that we could truly understand what the picture of COVID-19 and the spread of COVID-19 throughout the U.S. means for us. But at the same token, they're saying, go ahead and put COVID-19 on a death certificate more often than not. Go ahead and put it in under code 7.1, which is for laboratory confirmed testing only, when we merely think it's likely or possible that the patient actually had COVID-19 in the first place. Or, it doesn't seem to be any guidance on, let's do dual testing. If a patient has tested positive for COVID-19, please confirm and do testing for the flu to make sure there's not two infections happening at the same time. Or likewise, if they've tested positive for the flu, go ahead and test them for COVID-19. So we could see whether people are seeing a lot of dual infection, or if it's more likely than not, with any statistical certainty, that somebody, once they get one virus, they don't get the other at the same time. Okay. Feels like at some point we're getting into the weeds on this, but to me it seems to have severe impact on the numbers that we're seeing too. Have you, I think you might have mentioned that you saw either my paper or maybe my video talking about the different numbers that the CDC is currently reporting simultaneously, that they actually are putting out 2 different numbers for COVID-19 deaths. Have you had a chance to see any of that?
I have not, no.
Well, I guess I'll just put this out there, and if you have any thoughts that come to mind, great. If not, we'll just go on to the next thing. But so they have a portion of their website. There it is. So, and the full URLs are in the paper that I put on. But, so we have the numbers that are being reported to the media. The numbers that, when you just do a quick Google search and say, I want to know how many people have died from COVID-19 in the U.S., it's the number that you're going to have as that first result with Google or whatever search engine. Those are actually the provisional numbers. So those are the ones that are also including pneumonia. That is not a COVID-19 pneumonia, but they say, well, we're just going to grab that cause of death and put it in anyway. So as of 3 days ago, the death toll reported for U.S. Deaths with COVID-19 was 46,379. Does that sound vaguely like a, okay. So that number was available, like I said, on that one part of the CDC website. If you just did a standard Google search, it's the first one they funnel you to. It's the provisional numbers. However, on the same day, and I actually showed the screens to viewers in one of my videos. It said right at the top, data as of April 23rd, 2020. So the same data, same day. Also on the same CDC website, just in a different part. It actually lists that 23,358 deaths were due to COVID-19. Less than half. So one was in cdc.gov/coronavirus/whatever. So they're like funneling you right into this coronavirus stuff. The other portion of the website that I just mentioned, the much lower number, is cdc.gov/NCHS, or National Center for Health Statistics, /NVSS, which stands for National Vital Statistics System, /VSRR/COVID-19. It's a piece of their website you can't get to accidentally. You have to be digging hard to find. So they say right on there. In fact, Mike, do you mind trying to open that up, unlock it, and just show me the Google Chrome? And don't refresh anything, because I just want to be able to show them exactly what we were talking about the other day. So it basically, to me, I'm highly concerned because those numbers are clearly a little different. If you have 23,358 deaths that are actually being labeled as COVID-19 deaths, 7.1 on a death certificate, ICD code 7.1, but we're being given the number of, well, 46,379 Americans have died from COVID-19 so far in 2020. Holy cow, that number is literally 2 times the amount actually given that ICD code by the doctors themselves. Oh, look, here it is. Okay, so viewers, you're not going to be able to see this. I showed this to you up close on that video a couple days ago. But this is the same. You know what, for the heck of it, I'm just going to see if okay. I'm going to go ahead and try to show viewers real quick. This is what I'm showing him. Is it appearing okay? Okay, so, oops. Well, I'm going to put the camera in front of, or the computer in front of you, even though viewers, sorry, you're probably not going to see him very well now. So COVID-19 deaths, would you say it's an accurate reading, obviously just seeing it for the first time, that specifically says U07.1. And so comparing that or contrasting that, I guess I could say, to pneumonia deaths, those have a classification code of J12.0 to J18.9. Is that correct?
Correct.
So those would seem to indicate that's the use of ICD codes.
Yes.
So COVID-19 deaths as of April 23rd, because I haven't refreshed, I don't know what the numbers are as of today. But as of 3 days ago, total deaths in the U.S. is 23,358. Am I reading this right the same way that you're reading it?
Correct.
And so there's a footnote number 1 right next to where it says code 7.1. Do you see that?
Yes.
So if I scroll down to footnote number 1, it says deaths with confirmed or presumed COVID-19 are coded ICD-10 code U07.1. Is that correct?
Mm-hmm.
Even though that goes directly contrary to the specific directive of the World Health Organization to use 7.1 for laboratory confirmed and 7.2 for assumed or likely cases. Is that right?
Correct.
So they're putting right out on the website. This is the CDC. Hey,
right.
We're not going to do what the World Health Organization is saying. We're actually lumping all those into one category. Is that
correct?
Okay.
Correct.
And even though we have laboratory confirmed tests and presumed tests all in one category, I'm going to put this back on my lap so I can scroll again. Back up to that 23,358 number, even though we're taking confirmed and non-confirmed deaths and lumping them into one, that's still only 23,358, which is less than half of what the provisional numbers tell us for the same day. Is that concerning?
Very much so. And is there an explanation by the CDC as to why those numbers are so varied?
Well, see, I thought a couple of things, right? There's got to be an explanation. So, pneumonia deaths are on here. So we have COVID-19 deaths. We have deaths from all causes. So far this year, as of April 23rd, 644,934 people have died in the U.S. from all causes. So pneumonia deaths, they have reported, pneumonia deaths, 53,768 people have died. Pneumonia, not COVID-19. COVID-19 deaths is only 23,000. But we're not locking down communities because of pneumonia, okay? Deaths with pneumonia and COVID-19. That's actually its own category. So at first when I looked, I thought, well, maybe they're right. Maybe somehow this, it's, under the pneumonia category, we have people that have pneumonia, and also COVID-19, they're just going under that one category. But no, there's distinctly another category that lists 10,492 that have both of those codes. Is that what you would
correct.
see
Yep.
there? Okay. So, and then we have another category for influenza deaths. So my understanding is influenza and pneumonia are distinct, but pneumonia can be brought on by getting influenza. Is that correct?
Correct.
Okay. But people can have complications that result in death from influenza alone, or they can have complications that result in death that's more from the pneumonia side of the progression.
Or other medical,
okay,
underlying medical conditions.
So, to me, that's highly concerning. But then that made me think, well, because my husband asked me the very same thing. So, he's not an attorney. For those of you out here, my husband is a machinist, okay? So, he's not viewing this with, a trained medical background. He's not viewing this with someone who, like me, you might argue is trained to just argue the facts and twist and turn things and make it what I want. My husband is a machinist. He's just like millions of Americans who goes and does his job every day and enjoys his freedoms, listens to talk radio, listens to press conferences, and starts to think, gosh, that just didn't sound right. So with that mindset, he asked me the other day when I'm putting all this together, he said, why is it that pneumonia deaths are at 53,768 this year? COVID-19, even if we're including just the assumed deaths, is actually only at 23,000. And yet we have a provisional reporting of 46,379 deaths. So they're telling us the number's twice as high. How can that be? And then he said, maybe are they putting all of the pneumonia deaths under this category? And I'm like, well, no, because 53,000 is already greater than 46,000. So clearly they're not. But then it hit me. Oh, that April 2nd, COVID-19 alert number 3 that comes from the CDC's, Dr. Dave, or PhD Stephen Schwartz, director of the Division of Vital Statistics from the NCHS, on that date, April 2nd, tells us that, well, provisional counts are going to start including pneumonia deaths. So all pneumonia deaths until April 1st, those are not included in the provisional counts. And then we see this spike because all of a sudden we're going to start recording pneumonia deaths specifically not categorized as relating to COVID-19 by the primary health care provider involved in the case. We're going to include those anyway, starting on April 2nd, and report that as the provisional number. That is the number that's released to the media that you then see on a Google search. So when you Google on April 23rd how many people have died from COVID-19 in America, you are seeing 46,379 people have died from COVID-19, when in fact only 23,358 are actual deaths where the provider, the medical provider, signing that death certificate has said, hey, we think it's possible this person has died from COVID-19, or hey, this person was tested positive for COVID-19. To me, I don't know about you, I'm getting all fired up because the more I think about it, the more I hear myself say it out loud. People are so angry, you know, calling freedom fighters like me selfish. You're selfish. People are dying everywhere. Everybody can die if you go out and you cough on somebody, or your breath, you know, spores, or you know, the surfaces you touch, a gas pump, or when you go into a store, if you want to open up restaurants and you're going to sit next to somebody, you're going to kill that person. I had somebody tell me, if you're going to be dumb enough to go out and open your business when you don't need to, you're not going to suck it up for a few more weeks and everybody stays home and everybody gets safer. No, if I find out you opened your small business and my grandparent went into that business and they ended up getting COVID-19, oh, I'm going to come after you and I'm going to sue you. I'm going to bankrupt every single one of you involved with that. That's the kind of fear and irrational thinking we have about COVID-19. And yet, to me, it's coming from this very information, this one seemingly innocent little letter. It is one-page document that says we're going to start inflating our numbers even more because we didn't like how small the numbers were when we told doctors to put non-confirmed cases in with confirmed cases. I don't know. Am I overreacting here?
No, I think it's very concerning because obviously we're counting people who didn't die of coronavirus as dying of COVID-19, and that's not appropriate. That doesn't paint the picture we need to make policy decisions and to make medical decisions.
Well, I'd be curious. Obviously, you're a physician. You're deemed as being an essential business, and rightfully so. Quite frankly, we're all essential. We're all important. We all have jobs for a reason, but that's a whole other argument. Your business is, well, like we mentioned, you're an expert immunologist, and you also deal with things like seasonal allergies and other things that are probably looking out. At my lawn that was just mowed yesterday, it has a whole bunch of new dandelion or whatever flowers growing in there. So I'm guessing you're getting busier and busier. My point is that if you happen to have the time to reference that recent document I just put out and click on those 2 government links and you take a look and see, I'd love for you to tell me if there's just something horrible that I've missed, or if you do in fact see it the way that I see it. And my understanding is that a lot of these doctors that are out there, I think there was one in Louisiana, there were some in California, I believe there is a doctor down in Texas that was viewing this actual same information after I had seen it. They were viewing it, and that's the way they came out with that. I guess I'd be curious to know, since you're the only one I have personal contact with, if I am in fact looking at this the right way.
Well, based upon what you're telling me, and based upon what you just showed me, I think I already have. I mean, it's obvious that there's a huge discrepancy here.
Okay.
And this is very troubling. It's very, very troubling.